Welcome to All Things Cardio-Oncology. This is the podcast of the International Cardio-Oncology Society. My name is Steve Caselli, and I'm the Executive Director for ICOS. It's my pleasure to introduce my co-host today, Dr. Arjun Ghosh. Arjun is consultant cardiologist at Bart's Heart Center and at University College London Hospital. He's the clinical lead of the cardio-oncology service there as well. Welcome, Dr. Ghosh.
Thanks very much for having me, Steve. Really looking forward to this podcast.
And today we're going to have a conversation with two experts in interventional cardiology. Our first guest is Dr. Cezar Iliescu. He is an interventional cardiologist and the medical director at MD Anderson Cardiac Cath Lab. He's also the president and founder of the Interventional Onco-Cardiology Society. So welcome, Cezar.
Thank you, Steve, and thank you, Arjun, for the opportunity to be here and have a discussion about our common passion, interventional onco-cardiology.
Great. Our second guest is Dr. Kostas Marmagiolis. He is associate professor of cardiology at MD Anderson. He is also practicing interventional cardiology at Northside Hospital in St. Petersburg, Florida, which is a neighbor of where I'm located in Tampa, Florida. So welcome, Kostas.
Thank you for the invitation. This is a great podcast. It's a great effort from your team to help the field progress, especially in the area.
Very good. Well, thank you both for joining us. Arjun is going to have some questions for you in a moment about the role of interventional cardiology and cardio-oncology, but I wondered if first you could briefly each tell us sort of how you developed your interest in cardio-oncology, what your background is, and how you progressed in your development in this field. So Dr. Iliescu, maybe you could start and maybe tell us a little bit too about the Interventional Onco-Cardiology Society.
I appreciate it a lot, Steve, again. So my journey started back in Romania at National Hospital, where I completed training in general surgery in a group that was focused on surgical oncology, followed by internal medicine training and the opportunity to rotate at MD Anderson. At the time, I had the privilege to follow patients with superb clinicians that are oncology royalty, like Dr. Cantorzian, Dr. Champlin, Dr. Fossella, Dr. Wolf. So early on, I was exposed to oncology and the oncology challenges. As a cardiology fellow, then I found my MD Anderson rotation as a thrilling opportunity to take care of patients extremely challenging. And I remember vividly when JB was giving talks promoting treating patients with heart failure, cardioprotection, and re-challenging patients with life-saving therapies. And I actually did cardio-catheterization procedure with Dan when I remember we were doing the 4 French catheter cannulation of the ostial left main to diagnose CAD in patients exposed to radiation. As an interventional cardiology fellow, we were at the receiving end of patients with acute myocardial infarction. And we've early recognized there's no data on how to treat patients with cancer and acute MI, and that these patients, usually, even as of today, they're excluded from the major cardiovascular trials. And like everything in life, all these pieces of the puzzle came together when I recruited at MD Anderson by Dr. Ye for my first job as a medical director of the MD Anderson Cardiac Catheterization Laboratory. And I have felt privileged ever since to treat patients. And I think this is the biggest challenge of their lives, fighting for their cancer and surviving cancer. And it was a thrilling and exciting journey for both us and the patients.
And tell us about the Interventional Cardio-Oncology Society. What is that?
So this is the story of my friendship with Kostas. So we started our collaboration in early 2015. We have both felt excited about this field, and we've recognized the gap of knowledge for these patients in this field. And with the support of Dr. Grimes and the Society of Coronary Angiography and Intervention, we started this work together and I'm gonna let Kostas talk more about it, but at the time, we put the seeds of this Interventional Onco-Cardiology Society. We've waited to collect more data and more information and have more collaboration and members, to be honest, because it was just a small, limited group of people with interest in this field. And I think that at the beginning of last year, the time was right. So we started this initiative with interventionalists from all the from United States, Europe, and South America, and obviously we're trying to expand to the rest of the world.
Terrific, thank you. Kostas, you want to tell us a little bit about your background?
Yes, so my journey started a little bit later. It mainly started, I currently organize a conference in Greece, an international interventional cardiology conference. And this is how I met Cezar. Cezar was invited to present his experience from the MD Anderson Cath Lab. And just to make sure that your audience knows, the Cath Lab at MD Anderson is a very unique place. It's the only Cath Lab in the world, to the best of my knowledge, that it treats only or mainly patients with active cancer or patients with who are cancer survivors. So when Cezar presented in our conference and he presented his data, that was an amazing experience. It was an eye-opening experience for all the audience, from all the attendees, about how many things can be done with patients with cancer. And again, cardio-oncology at that time was in the first steps, but interventional cardio-oncology was pretty much inexistent. There was no experience in the literature and no experience in any cath lab about how to treat the cancer patients in the cath lab. So when Dr. Iliescu presented his data, and he presented the experience of hundreds and hundreds of patients with complex progressed cancers on chemotherapy, on radiation, with very low platelets, with very low hemoglobin, I realized that this is an emerging field, and this is how we create a friendship with Dr. Iliescu. We tried to look at all the data from MD Anderson, and we started conducting clinical research, some prospective, some retrospective, some observational. We started promoting randomized controlled trials in the field, and we realized that it is an amazing field. And over the last years, we realized that the data was so impressive that we suggested to SCAI, to the Society of Cardiac Intervention and Geography, to publish a guideline, expert consensus statement. And at that time, SCAI was very skeptical, but after the publication, it was very well received by our colleagues. And I think that after the publication of this consensus, there has been an accelerated progress in the field. We start seeing that other groups internationally were working on the same things that we were working, and we start collaborating, and we start seeing a lot of publications. We recently saw a new JACC Cardio-Oncology journal being out, and I'm sure there will be much more articles and much more journals, because there's an increasing interest from the society about cardio-oncology. So my collaboration with Dr. Iliescu has been in clinical research and trying to make the best use of our accumulated experience, as well as developing the best practices in cardio-oncology, in interventional cardio-oncology.
Well, that's terrific. It's obvious why we wanted to have you two on the program today to discuss interventional cardio-oncology. So, Arjun, you want to follow up with some questions?
Yeah, thanks, Steve. So I think Cezar and Kostas, you've already very nicely touched upon some of the potential issues in interventional cardio-oncology. So both of you were involved in the SKY document, which I personally have actually used myself in my institution, and it's been used by others I know. So it's a very useful way forward in the field of interventional cardio-oncology. So do you think that it's really with guidelines and statements, position statements from different organizations that we can take interventional cardio-oncology forward? And allied to that, with guidelines, you need evidence. So I think you already alluded to the fact that a lot of cancer patients are excluded from interventional trials. So how can we kind of manage these two issues? Cezar, maybe if you could start us off.
Absolutely. So, Arjun, thank you. So, we recognized really early when we started our practice that we have several challenges. The first one, I called it timeline challenge. It means that cancer care has to be expedited on one hand, and on the other hand, is the cardiovascular care requires time and defined periods of DAP, dual antiplatelet therapies. So it made it very, very complicated. And philosophically, we had this approach where the patient was coming to the cardiology clinic, was recognized to have cardiovascular disease, but because of the cancer pressure and constraints, we're pushing the patient towards the cancer care without addressing the cardiovascular component of it. So we've learned it over the last decade to alternate basically cancer care with cardiovascular care, many times do them at the same time, taking advantage of the progress in stent platforms and eluding medications. And Kostas alluded to it. The second big challenge we had early was thrombocytopenia. We had initial sporadic experience with cases where patients underwent procedures with low platelets. We're able to identify the patients are, I call them high risk, the patients that are actively bleeding, septic patients that we start excluding from our cardiovascular evaluations. And we start focusing on patients with what I call chronic thrombocytopenia, where this is their baseline. Sure. And we're able to perform complex procedures on them and have an approach right now where a lot of people throughout the world start embracing it. And as you say, I think this document that we did in a very comprehensive group with a lot of brilliant and experienced cardiologists being part of it, I think was a reinforcement of just going towards the patient, try to save these cancer patients, and I think it moved the field forward. Another issue that I realized was we do not have a plan B in this in our cancer patients, and that is very, very challenging. In a normal cardiovascular practice, when the complexity of the case exceeds the interventional armamentarium, or we have a complication, then obviously we have the surgical backup that as a bailout strategy. Our patients are so frail, and because of the additional comorbidities and obviously cancer timelines that need to be addressed, it is very, very challenging to have a plan B. And I think that was the biggest challenge I found in the very beginning, that there's no room for any mistakes. So I think that the operators have to be experienced, they have to be meticulous, they have to spend the time doing those complex procedures. And I think that was why our collaboration was really fruitful, because we had the two components of it. We were academic medicine with a different tempo and different approach to things. And Kostas was real life, really, in an extremely busy practice with all the complexity that comes, from having a very busy practice and doing extremely complex cases. And I think over it, we're gonna go through this, through the challenges that they faced when they saw the first patients and what the challenges are in a really real life cardiovascular practice, and the challenges we saw as well on our academic side of developing an intervention program.
Sure. And Kostas, maybe if I could ask you, you did allude to it a little bit earlier about getting patients into the interventional trials, cancer patients being excluded. So yes, what do you think the best approach is to maybe change the status quo?
So because of the expectation of life of the cancer patients being different than patients without cancer, the best way to do it is, first of all, realize that not all cancer patients are the same. There are patients with cancer which is metastatic, patients with active cancer which is controlled, and patients who are cancer survivors. So in clinical trials, we try to separate those three. And in order to be able to have some meaningful outcomes, we have to compare patients from the same group and whenever we have an intervention, so we reach meaningful results. Unfortunately, compared to all the other subgroups of patients, we cannot really get any results from the randomized control trials. All the randomized control trials have excluded the cancer patients. So we have to start with new trials, and we involve patients with the same comorbidity states, the same survival, same prognosis in cancer. And there's a lot of work to be done in cardio-oncology. That's a major challenge for us. And this is why most of our research is small number of patients, and they most come out of MD Anderson, which has a large number of cancer patients, so they can get some meaningful outcomes. Or we use the meta-analysis. So we get observational registries, observation trials or registries, and mainly the NIH database. And we try to extract data out of that, making sure that we compare the similar groups of patients. So this is, from academic standpoint, this is the challenge. Now, from the real life standpoint, as I'm practicing in a non-cancer hospital and in a non-cancer cath lab, is to convince interventional cardiologists in the area to use the cath lab for the benefit of cancer patients. And this has been easier and easier every year as people read in the journals the outcomes of different trials. So they start being less scared, let's say, from referring the patient to the cath lab, even with active cancer. With experience from MD Anderson, now we can pretty much do a coronary angiogram to anybody, as there is no minimum platelet count or minimum hemoglobin. We pretty much can do a diagnostic cath to anybody. The other challenge from practicing standpoint is that there's an continuous expansion of chemotherapy agents, and there is new data every day about the cardiovascular toxicity from medication. So practicing cardio-oncology in the past required some basic knowledge, but more and more the practicing cardio-oncologists, they have to keep up with a expanding list of chemotherapy agents or cancer therapy. And not only that, about the new data about the toxicity of those agents. So not all patients with cancer are the same. There are different cancers which cause thrombosis. Some of them cause bleeding. There are some chemotherapy agents that accelerate the stent healing. Some of them that they decelerate the stent healing. So in our field, it's very challenging. You have to keep yourself updated all the time, because every cancer patient is a different case.
Sure.
The last challenge is collaboration with oncologists, and this is something that we can hear in different countries, in different hospitals, and in different states. It is extremely important in our field to create those multidisciplinary decision meeting teams, a collaboration between general cardio-oncologists, interventional cardio-oncologists, and oncologists, so that the decision is made collaboratively, and it has to be done in a timely manner, because cancer patients cannot wait from getting to be seen from different specialists until they reach a decision. You have to establish in every institution a multidisciplinary decision team we meet once a week, so we can make the best decision for the patient in a timely manner.
Sure. So that actually leads me nicely on to one of my next questions, Kostas, and I'll direct this at you. What advice would you give to an established interventional cardiologist who's listening to this and thinking, well, I do see cancer patients and maybe it would be interesting in my local hospital to set up some form of service for these cancer patients in the cath lab. You have done that in a hospital outside of MD Anderson. You've done that in your local service. So what advice do you have to such a cardiologist?
That's a great question. The first thing that needs to be done is to meet with the local leaders in cancer care in the area. And I think the most important step is to create this meeting. You find the time that all the doctors, all the specialists can meet. And it can start with a half an hour decision meeting. Usually everybody's very busy in the private practice. So you find time that is very convenient for everybody. Bring interesting cases and start with 1 or 2 cases each time. And try to convince your colleagues that you have something important to bring to them. And they have to be weekly meetings with oncologists. Invite your cardiac surgery colleagues, invite your fellows. And I think after we started that, it went in autopilot. Then more and more people would bring cases. Referring doctors would bring their cases for discussion. And little by little, we build the program.
Okay. And who did you need to convince the most? Was it your cardiology colleagues or your oncology colleagues?
I think the oncology colleagues were the most, let's say, resistant to those meetings. Because they have their own meetings, the tumor board.
Yep.
And they have other meetings with GI and other specialists and other general surgery meetings. So they have a lot of meetings. So it was more difficult to convince our oncology colleagues to accept the invitation and participate. But after they did it once or twice, it came very naturally. So right now it's one of the most successful meetings.
Okay, that's great to know. So one of the aims of ICOS is to promote training in cardio-oncology, and we would very much like to attract more interventional cardiology trainees into considering cardio-oncology as maybe their main career or maybe one of the parts of their job when they become established cardiologists. So what would the majority of cardio-oncology trainees are actually not, as you know, from an interventional background. So how can we attract interventional trainees into cardio-oncology? And maybe, Cezar, if I could start with you on this one.
Thank you, Arjun. So basically, we're privileged at Anderson. We have 2 sets of heart failure of cardiology fellow rotating with us. From Texas Heart and from UT Houston. And the UT Houston program is a program I train. Basically, they do rotate between 6 and 12 months with the MD Anderson team on different aspects on the floor. So they go rounding on the inpatient service. They do echo and an echo rotation. And obviously, they get exposed to all the cardiac catheterization procedures that we do. So they cover our cath lab for half of the year, so 6 months alternating in our cath lab. So they get exposed to our hemodynamics assessment. We get them excited about, looking at all these patients with constriction, restriction. Yeah. We're doing complex pericardiocentesis with low platelets. Endomyocardial biopsy in our new subgroup of immune checkpoint inhibitors, plus the classic one on amyloid. And then, of course, our interventions. We use in the cath lab IFR, FFR, so to delay interventions. And by doing that one, less stents, less need for dual antiplatelet regimens. Oh. We talked about OCT and get them excited about using OCT to assess exactly what Kostas said, stent healing, and you have this abbreviated course of DAPT. So once you get them excited and they see all the tools we have, and they obviously going back in the community, they start practicing, and it feels natural to them, to do procedures on these patients, which are very, very complex, and otherwise would have been just delayed. Now, we get calls from all over the country from our trainees, where they have all these successes on extremely complex patients, because they're just open to it, which we've not been before, which is great. And the second set of fellows, we have the fellows from Texas Heart, where they really come specifically for certain procedures we do, like thrombocytopenia and pericardiocentesis, where we get them exposed to subxiphoid, apical, and all these particularities. And of course, when we get excited, they go out. And I think it just becomes natural to them to continue and do these procedures. I do believe, Arjun, is that it's a process of maturation of the field. And I think you're going to see what happened to oncocardiology as a field is going to happen to interventional onco-cardiology. I think that, the need was there, the patients were there, but it needed a maturation of the field and of the knowledge to get people excited and get them busy with this. I think at an interventional perspective, we had 4 or 5 years ago, we recognized that, the cancer patients subgroup was undertreated. And even at the societal level, SCI is promoting interventions and doing procedures in patients that need it. And of course, elderly, and there immediately after that, or the cancer patients, they were completely undertreated. So I think that that's going to happen as well. I think that ICOS is doing a superb job in promoting the field and expanding the field nonstop, and we're really excited to see what a tremendous role ICOS has done in expanding the field and opening it. And I think it's just it's going to be a natural immersion of the interventional and EP and multimodality imaging specialists, to come in and be part of the field and expand the field for our patients.
Sure. And Kostas, maybe if I could ask you, if there's an interventional trainee outside of a center with links to, say, MD Anderson, maybe they've listened to this podcast or for some other reason is, interested in interventional issues in cancer patients, where can they get training locally? I mean, is this something that should be incorporated in the interventional training program for all interventional trainees, or can they avail of this locally, or do they need to contact you guys for a fellowship?
Well, at this moment, there is not any interventional cardio-oncology fellowship program, as you probably know. But most cardio-oncology fellowship programs, although they focus on consultative service, imaging, congestive heart failure, and management, there are many places that the cardio-oncology fellows participate in procedures, especially like Dr. Iliescu mentioned, high-risk pericardiocentesis, biopsies, procedures that we don't do very often in the non-cancer patients. So I personally think the best place to train for this new subspecialty is MD Anderson, and maybe it's one of the few places in the world that they can provide an experience. Now, going forward, I think that most interventional cardiology, and I think most of the interventional cardiology places include cancer patients, but I think that little by little, the cardio-oncology specialists should participate in the decision meeting and maybe participate in those procedures. So little by little, the field of cardio-oncology expands to the interventional field, and vice versa. Interventional cardiologists be more comfortable doing procedures in patients with cancer, and more expert and more confident in dealing patients with cancer.
Sure. So it sounds like, Cezar, that you need to set up an interventional fellowship specifically for interventional cardiology trainees.
Actually, Arjun, you gave me the opportunity to congratulate the Jack Cardio-Oncology team, and the fact that he came up with this how-to series which I find them extremely helpful exactly to cover this unmet need, where we have the specialists in the field describing in detail how they do these procedures, how they go through steps. I do believe that with just paying attention to some particularities of this patient population, everywhere in the world, the cardiology interventional training can embed in their training program certain skills and certain procedures to be able to accomplish this thing. So I do not think I think that would I think that a combination of, as you say, how-to series, meetings the way you have, and podcasts the way you're doing it, the training program, and maybe expanding the curriculum to where we add maybe a few weeks or months with specific focus on cancer patients. And then, of course, the national meetings where we go and describe our experience, and we get questions from excited young lads about how we do these procedures and how we accomplish this one. I think we'll all together come and we'll push that field forward.
Great. Thanks so much for that answer, Cezar. And maybe to finish, I'll ask one last question. If I were to ask you to give a one-line pitch to interventional trainees as to why they should consider developing an interest in interventional cardio-oncology. So if I could ask you first, Kostas.
So the advice I have for them is that they should realize that the population of cancer patients and survivors is only gonna it's only gonna keep increasing over the next years. So having to deal with cancer patients was easy before, but now it's gonna be an integral part of the practice in the near future. So getting involved in reading, studying over the cancer patients and their specific needs of this population, and being able to manage them in the cath lab is extremely important for their career. And after reading our consensus document and the document we have on the circulation vascular toxicities, those are the first documents that should start reading and understanding what we're doing, because sooner or later that will be a common theme for their training in real life in the next years.
Great. And Cezar, if I could ask you the same question, one-line pitch to entice interventional trainees into this field.
I do believe that cardiology is a mature field. Onco-cardiology field is a field that has to be defined. And I think that's where it's a great opportunity for young people to get excited and answer these unanswered questions. We've learned this history with a lot of diseases. I do believe this fusion field between oncology and cardiology, and especially us with the interventional part of it, it is a completely uncharted territory. And again, we were privileged, both me and Kostas, to have a really a lot of success, and a lot of we're thankful for that, for the opportunity. And I think there's so many things to be done. So everyone who's young and excited in this field is going to have a place to publish, to present. And I do believe probably for the next 20 years, so for you for sure, Arjun, is going to be a great path ahead, because it's, again, all these young people the way you are, excited and knowledgeable, have so many things to say and add to this field. So I think that it's a great opportunity for whoever wants to try it.
Great, thank you, Cezar. I think that's a very nice summary. So very interesting discussion. Thank you to both of you. I'll hand back to my co-host, Steve, now.
Yeah, thank you both so much for your time, Cezar and Kostas. This is just so fascinating to hear about the pioneering work that you all are doing to really care and provide the best possible care for cancer patients. I wonder if folks are interested in learning more about the Interventional Onco-Cardiology Society. Is there a website, or how can people find more information?
So our website will be up next week. We have already completed building it. It will be at inocs.org. It will be up next week. And I think it's going to be a great place for people interested in the field to see how they can train, how they can collaborate with us. They will see what is going on in the field of research, so they can either participate or see where we are, so they can go a step forward. I think it's a great platform for people interested in the field.
That's terrific. INOCS, INOCS.org, is that right?
That's correct.
Yep.
Not to be confused with ICOS, IC-OS.org.
We will talk. We will talk to them. We're gonna try to get absorbed by ICOS.
That would be terrific.
We just have stainless steel in it. That's why it's INOX. We
Very
have
good.
the alloys in the stents. Yes.
Perfect. Well, we're be thrilled to partner with you all in this fascinating work that you're doing. It really is pioneering, and we are so glad that you took the time to be with us today. So thank you for your time and for the amazing work that you're doing.
Thank you both.
Well, thank you for letting us discuss our passion for the field. And you can share our contact information if you have any of the audience who would like to reach us either via the society or with our emails. We are open to any comments or suggestions or questions.
That's terrific. I'll put that information in the show notes so people can find it there. And I want to just close by reminding our listeners that we have a certification exam in cardio-oncology, and that exam will be offered again on May 22nd. You can find information about that and all our other activities at our website, ic-os.org. And we trust this has been a helpful and inspiring time for you. So thank you for joining us today.